So thank you for that very kind introduction, and thank you, Dr. Gibbons, for laying out the framework. I'm going to focus in on nutrition, obviously, from my role at the Center for Food Safety and Applied Nutrition. And I'm a big believer in a lot of the discussion on precision nutrition. Part of my former academic career was looking at new sensor technologies to measure nutritional status in skin using lasers through Raman resonance spectroscopy. But today I'm going to take a step back, and I'm going to talk more about population issues in population prevention in the setting of nutrition. You've probably seen some of these statistics. I'm going to go through very quickly. The burden of diet-related chronic disease in this country is enormous. These are the most up-to-date data from CDC, and you can see heart disease and cancer dominate mortality and healthcare costs. Also, many other diet-related diseases are on this top 10 list, things like diabetes and also stroke. And as I will argue today, nutrition is one of the most important behavioral risk factors try to impact on this tidal wave of chronic disease we have in this country. The patterns are similar in men and women. You can see here, again, heart disease and cancer dominate with all the other chronic disease outcomes. You can see other causes of death as well. And this is not only a U.S. phenomena, this is also a global phenomenon. And in the global landscape, we refer to it as non-communicable diseases. And what we now see is around the globe, people are not dying of infection and malnutrition and things to nearly the same extent as they are from chronic diseases. So the same trends that are happening in the US are happening around the globe, and it's the same diseases, as you can see broken out here: cardiovascular disease, cancer, again, dominating the global landscape of chronic disease and the problems we face in global public health. So in terms of what do we do about this, there is exciting research going on, as you just heard about the genetic determinants here, about the numerous ways that your environment can impact. But at the same time, as I indicated, diet and nutrition is here and available now to help impact this global wave of chronic disease. Dr. Gibbons also made the point that this starts early in life. We are seeing childhood obesity now at record prevalence rates that we have not seen before. We're seeing type 2 diabetes now in kids. So this needs to happen early in life. And some of the work that FDA is focused on that I will share with you here today is to try to impact those trajectories early in life and make an impact on this global burden of disease. Speaking of the global burden of disease, there's a study that came out in 2017 looking across the globe and looking at the potential impact of dietary interventions to impact the global burden of disease. And what you can see, well, I'll show you in a second, what the study concluded was that diet was probably the most important risk factor, even beyond tobacco, in terms of impacting the global burden of disease. And what is it about diet that was quantified in this particular publication? On this slide, you can see, maybe you can't read it, but I can read them for you, is the key things are some of the traditional nutritional risk factors that we have known about for decades. Number one, diets high in sodium. Number two, diets low in whole grains, diets low in fruits, diets low in nuts, diets low in vegetables, diets low in omega-3 fatty acids, that's seafood, diets low in fiber, et cetera, all the way down. And then at the other end of it, diets that contain too much sugar, diets that contain too much processed meat. So those are some of the risk factors that they've elucidated in this article on the global burden of disease. So these are traditional risk factors that we've known about and that we need to really move into population prevention to impact this problem. And you may read articles about uncertainties in nutrition science, what's true, what's not true. A recent study about red meat didn't have RCT data showing necessarily that red meat could impact long-term chronic disease. There's a lot of evidence out there, and it's quite robust and consistent, and it includes randomized clinical trials for many of the same risk factors that I'm going to highlight today. Oftentimes, it's combined interventions. This is a study that came out 20 years ago, showing that a lifestyle intervention given to patients who had impaired glucose tolerance, that is, they're on the path to diabetes, a lifestyle intervention could prevent type 2 diabetes. This was the Finnish diabetes prevention study. There have been many other clinical trials showing lifestyle interventions. This one focused in on diet, physical activity, things like that, showing prevention of chronic disease through a lifestyle intervention. And again, this is 20 years old information. nutrition that we need to translate into our populations. So how do we translate it? Well, one of the things that FDA works on is we are part of the Dietary Guidelines process. Dietary Guidelines are done jointly between the U.S. Department of Agriculture and Health and Human Services, and FDA is part of HHS, and so we participate in the Dietary Guidelines. The most current iteration of the Dietary Guidelines is 2015 to 2020, but they are constantly being updated, and that process is underway right now. So what are the key recommendations in the Dietary Guidelines? Well, it's the same things you just heard about in the Global Burden of Disease study. It's making sure that people consume the things that are under-consumed in our diet that are important for disease prevention, things like vegetables, fruits, grains, especially whole grains, fat-free or low-fat dairy, and a variety of protein foods, some of these lean protein sources, and healthy oils. Those are some of the key things in the Dietary Guidelines. And at the bottom is avoiding overconsumption of nutrients that we know damage our health. Saturated and trans fats, added sugars, and sodium. Again, we've had evidence on these for decades, so we need to translate that. One of the things that the 2015 to 2020 Dietary Guidelines did is they proposed quantitative limits on the nutrients that we need to limit, and those had existed previously for things like saturated fats and for sodium. But for the first time, the Dietary Guidelines put forward a quantitative limit for added sugars in our diet. And what the Dietary Guidelines said is no more than 10% of calories should come from added sugars. So that was a key thing for FDA, as I will come to in a few minutes, as we were updating the nutrition facts label to indicate that we need to put this on a label. Because if the Dietary Guidelines is telling Americans to reduce the amount of added sugars in their diet, if it's not on a food label, how are Americans supposed to do that? So that was a key part of the science that FDA needed to move forward with mandating added sugars on food labels, as I will come to in a few moments. All right, so you've heard what Americans are supposed to be doing with regard to diet, and you've heard that we've got a global burden of chronic disease here in the US and abroad. And why is the discrepancy? If we know what to do, why do we still have all of this chronic disease? Well, the main reason is people don't do what they're supposed to be doing. And what this summarizes is the benchmarks in the Dietary Guidelines, what people are supposed to be consuming versus where we actually are. And the middle bar is kind of the benchmark where you're supposed to be, right here. This is the benchmark. And the blue indicates that the population is under-consuming, or for the ones where the blue is on this side of the benchmark, over-consuming. And so what you see is our population is under-consuming vegetables and fruit and whole grains and dairy. Protein is consumed at the approximately, similar to the benchmark. Some people are under, some people are over. Oils are under-consumed. And what we're seeing is this problem of overconsumption of added sugars, saturated fat, and sodium. My God, look at sodium. We overconsume sodium so much in this country that contributes to cardiovascular disease risk. So that accounts for some of the discrepancy between what we recommend consumers have versus what we actually see played out. So is it all bad news? No, we are making progress, although it's too slow and it's not even across the population. One of the ways we assess progress is by a measure called the Healthy Eating Index, and this looks at adherence to the Dietary Guidelines in the population. And what you can see is from 1999 to 2000 up into this period of time, we are making progress, but 100 would be meeting Dietary Guidelines, and we're in the 59 range, so there's enormous range for improvement. A new study came out quite recently looking at updated data on the Healthy Eating Index. Again, incremental progress, but what we're seeing is the progress is not uniform across the population. What we're seeing is there are racial and ethnic disparities here, that some of our poorest groups here in the population are not improving at all, and we need to do more. We need to address that. Dr. Gibbons noted that this need to get into these communities that have the burden, highest rates of chronic disease, and that are not seeing benefits from some of the dietary guidelines that I highlighted earlier. So we need to do more. So what is FDA doing? Nutrition is one of our mandates. The other is food safety, as you heard. And what we do is we use this conceptual framework, and we start with robust science. Everything starts with robust science. And we are in close partnership with the NIH that funds an awful lot of that robust science. We have a joint agency nutrition leadership team that meets regularly with NIH to talk about data gaps and the science around nutrition, so we start with the science. Then we apply the tools that FDA has. Those are things like labeling, reformulation of foods, what's allowed and not allowed in foods. We use those tools. And there's two pathways here. One is to give consumers information to change behavior, to get the public health outcomes we need. That's the upper pathway shown in the conceptual framework. The lower pathway is reformulation, where we produce a healthier food supply for all of us that doesn't require behavior change to get improved public health outcomes, and I'm going to give you some examples of that as well. And it's an iterative process where we continually evaluate where we are and what we need to do to improve on the public health outcomes. Our former commissioner, Dr. Scott Gottlieb, was very committed to the role of nutrition in chronic disease prevention. And last year, he launched what was called the FDA's Nutrition Innovation Strategy. We launched it at a public meeting in March of last year, and this was a quote that Dr. Gottlieb put forward at the time he announced our Nutrition Innovation Strategy. And I think it's a really important quote from a former FDA commissioner. Improvements in diet and nutrition offer us one of our greatest opportunities to have a profound and generational impact on human health. The public health gains of such efforts would almost certainly dwarf any single medical innovation or intervention we could discover. And that's from a commissioner of the FDA. So, what are some of the things that FDA has been working on? I have been at the FDA now for 5 years, and what I'm going to show you is some of the work that we've done over the past 5 years to try to impact on this problem. The first one I alluded to was the nutrition facts label. The nutrition facts label first appeared on food packages about 20 years ago. It's kind of hard to imagine that 30 years ago, it didn't exist. There was none of that information on packaged foods. But it's now been out there for about 20 years, and it was due for an update. So FDA has been working to update the nutrition facts label for the first time in 20 years to make sure that consumers really have actionable information to make healthy food choices. So what's shown on the next slide is the side-by-side comparison of the older label and the new label on the right. And hopefully the first thing you will notice when you see these new labels is the greater prominence of calories. And that's because of the obesity epidemic that we have. We want to make sure that consumers don't have to search hard in a label to find the calorie information. We've also made serving sizes much more prominent, and servings per container, that has been made more prominent as well. And that's to really give consumers actionable information. There have been other changes as well. I won't walk through all of them here today to save time, but a key one I already mentioned is the new requirement for added sugars. So you can see here under total sugars, there's a new line, includes 10 grams of added sugars in this product. That's really important because sugars have been added to a lot of our food, and consumers would essentially be unaware of that information, but now consumers will have that information as they move forward. There's other labeling changes that we have made as well to the nutrition facts label. One of the ones has to do with portion sizes and making sure that consumers really understand the calories they may be consuming. And in this case, what we've changed is that calories and other nutrients must be declared for the entire package if the package is up to 2 times what we call the reference amount customarily consumed. So if the reference amount, for example, for this beverage is 12 ounces and it's marketed in a 20-ounce bottle, this needs to declare the entire calories for that package, not the 12-ounce one, which could be misleading to consumers if they don't do the math, calculate how many servings per container. So again, to make sure that consumers have easy-to-identify information. The timing for the NFL Nutrition Facts Label update, not the football league, the timing for this update is new labels are mandated by January 1st, 2020 for the large food manufacturers, so that's a month and a half away. They get 1 extra year for the smaller food manufacturers, so you are seeing these labels in the marketplace now as they transition from the old label to the new label. So that means we have to do a lot of consumer education because we've got new labels. And so we have many tools that we have been developing to help consumers understand the new labels. We have a lot of information on our website. We have a whole consumer education piece, and we're going to be launching a big campaign hopefully next March, which is National Nutrition Month, to really make consumers aware of the new label elements and how they can use them. Again, focusing in on added sugars. That's a new thing that consumers haven't seen before, and we're going to have to make sure that they understand what it means and how to use the information. All right, now transitioning to another piece of nutrition information, and that's the issue of menu labeling. What we have learned is that our eating habits have changed over time. Americans now consume about 1/3 of their daily calories away from home. That's in restaurants and cafes and movie theaters, and when you go to the grocery store and you get takeout food and you eat it at the grocery store, we eat a lot of our food away from home. And previously, that food was not required to have nutrition facts or calorie declarations or anything. So it's important that consumers have calorie information across the food landscape. So menu labeling was implemented, and FDA has been working to implement menu labeling. And it's important because even small changes in the amount of calories that people consume, amplified over a daily basis across a year, across multiple years, can be sufficient to change the tide on things like obesity. For example, one study estimated that 64 fewer calories per day would be needed to reduce U.S. youth obesity rates. And again, multiply that over every day, 365 days per year. That kind of a change could be sufficient to turn the tide on children's obesity. So May 7th last year was the compliance date that now chain restaurants, similar retail food establishments now have to declare calories on the menu so that when consumers are purchasing or ordering their food, that they have calorie information available. And so that is the first time there has now been a uniform national standard for providing consumers with information that can be helpful in terms of the obesity epidemic. So what do the labels require? They require that there be calorie information on menus and menu boards for all standard menu items for covered establishments. These are chains of 20 or more. For foods on display, like if you go to a bakery display case in a chain bakery, the calorie information has to be on the display at self-service foods. There also has to be a statement that says 2,000 calories a day is used for general nutrition advice, but calorie needs vary. The reason that's included is that there was some scholarly research that indicated just providing calories without an anchoring statement so a consumer understands what it means in terms of their daily calorie requirement didn't get the same behavioral change. So that's important to help consumers understand what the daily requirements could be for individuals. Another key part is they have to also provide what's called the Statement of Nutrition Availability. It says additional nutrition information available upon request. That means if you walk into a restaurant that's covered and you want to know what the sodium content is in those foods, you simply request additional nutrition information, and they are required by law to produce that. And that's the last bullet. So this is important in terms of giving consumers information about sodium and saturated fat and calories and things that are consumed away from home. We've looked at some of the issues. This is an FDA publication that just came out quite recently, looking at consumers' understanding of daily calorie requirements. And the results didn't really surprise me, but we've documented essentially that consumers don't even understand what their daily calorie requirements are. The 2000 is general nutrition advice that I mentioned previously, but this was a study that looked at consumers' understanding. In the article, we looked at disparities, like who's most likely to understand what their calorie requirements are. The least likely group to understand calorie requirements were men. Men were 4 times less likely to understand it than women. We also saw strong racial and ethnic disparities. Hispanic respondents, African American respondents were less likely to know what their calorie requirements were. So we've got room to do more improvement in this area, and we're working on that. So one question I often get is, well, how do you know it's actually going to have an impact? giving consumers information is one piece of it, but is there any scholarly research to indicate that it actually has an impact? And the answer is yes, there is scholarly research to indicate that. This is an example of one study that came out last year from Rand Corporation. It was a large study, 2,200 respondents, where they essentially present them with different menus, with different calories, with and without calorie declarations, and track ordering behavior. In this case, what they documented is a decrease in about 7% of calories across all settings when people were presented with calorie information at the point of purchase. And again, 7% may not sound like a lot. In this case, it translated into 30 kcals per item ordered. But if you recall that 64 kcals is enough to change the trajectory of childhood obesity, this could get you halfway there with one intervention, assuming that that translates across populations. We're working on consumer outreach and education. We have a social media campaign to try to get this out. The key steps in our social media campaign, number one, is find out your calorie needs. And we turn people to web-based resources so they understand what their calorie needs are. Number two, look for this information. Look for calorie information on packaged foods and on restaurant foods. And number three, make the best choice for you. And we've got a lot of examples of where good choices could have an impact. And we have a whole social media toolkit around this if people want to help amplify our message. Now, one part about labeling is when you calculate the benefits of labeling and you're looking at like how does human behavior change as a result of labeling, that only captures part of the benefit. And the reason is, one of the things we know is that when labels come out on foods, that leads to reformulation by industry. And that's a whole nother piece of the benefit that we need to quantify when we look at the benefits of labeling. And what I'm talking about is things like reformulation. And one of the things we know is that nutrition facts labeling, for example, on things like added sugars, is driving reformulation in the food supply right now because industry wants to reduce the amount of added sugars now that it's going to be declared on the label. It drives reformulation with calories, menu labeling. There's science showing that that can reduce the amount of calories in foods offered in similar retail restaurants and similar retail food establishments. Simply declaring it leads industry to try to reduce some of the calories. Added sugar, sodium, trans fat. I'll come to trans fat in a moment. FDA mandated trans fat labeling on the nutrition facts label in 2006. Simply putting it on a label led to an almost 80% reduction in exposure in the population because people were looking for it and reformulation occurred. So what are some of the other things FDA is doing in the reformulation space? There's a lot, but the one I really want to focus in on right now is sodium. So what FDA is working on are voluntary targets for the amount of sodium in about 150 different categories of foods. And the importance here is that most of the sodium that we consume in our diet comes from processed and restaurant foods. And even people who have PhDs in nutrition who want to reduce their sodium intake have a hard time doing it based upon what's in the US food supply. So people can say things like, oh, I don't add it at the table, I don't add it when I'm home cooking. That doesn't have a huge impact on your sodium intake. You've really got to drive down the amount of sodium in foods, in the processed and prepared foods market, in order to drive down sodium intake in the population. And one of the things we've learned by studying this issue is that there's quite a lot of variability in sodium across similar foods in the food supply that indicates to us that reductions are certainly possible. I'll show you a graphic of that in a moment. So what FDA did is we put out draft targets across 150 different categories of foods. We then got back a lot of public comment that we've been working through before we finalized that information. We also looked at the new DRI report on sodium. There was a new National Academy of Sciences report on sodium that came out that indicated, again, that the science is robust, the science is strong, and people should not consume more than 2,300 milligrams a day for chronic disease risk reduction. So we've been reviewing all that information as we move forward to issue short-term targets. Now, I mentioned variability. For the 150 different categories, we have histograms like this. And this is one category, happens to be pre-cooked sausage. And what I'm displaying here is the amount of sodium in milligrams per 100 gram of food. And what you see is, and these are based upon top-selling products in the marketplace, top-selling products. And so what we have is products that range from around 400 milligrams per 100 grams sodium in the food supply, and products that are up around 2,000 milligrams per 100 grams sodium. And when you look at that, what that tells me is these don't need to be this high. Can we get these to come down in a gradual way? Sodium is an acquired taste. Can we get those to come down to improve population health? So that's the underlying principle behind our sodium targets, is incremental changes to reduce exposure to sodium in our population to impact public health. All right, the last example I want to cover is trans fat, and I think this was a really important one. This is another reformulation example to reduce exposure to partially hydrogenated oils. So again, there's a robust body of science that's been out there for some years indicating that trans fats are adverse for health and translate into tens of thousands of coronary heart disease events. And so FDA reviewed all of that evidence and basically said, we need to do something about this. And so what did FDA do? First, as I indicated, we mandated it being put on a label, a nutrition facts label, so that consumers know how much trans fat is in the foods that they were consuming. Second, we then determined that partially hydrogenated oils, which are industrially produced trans fat, were no longer considered generally recognized as safe. If they're not generally recognized as safe, they cannot be entered into the food supply as a food additive. And so that has essentially, we did a tentative determination, then a final determination. And essentially what this says is they can't be allowed into the food supply anymore. So that will reduce the amount, obviously quite dramatically, in the U.S. food supply of these partially hydrogenated oils, eliminating them from our food supply. And people have done some analyses, what's the potential impact of these kinds of changes. This was one paper that came out in 2015. Reducing intake of industrial trans fat could substantially decrease CHD mortality and hospital admissions and gain tens of thousands of life years. So these are big public health impacts that we've been working on. And while FDA has led a lot of this work on eliminating these PHOs from the food supply, it's now happening globally. And so other countries are coming to us and asking how we've done our work, how they can move forward and implement some of the same changes to have a healthier food supply at the global level. So my last comment is on labeling. We are updating the definition for the term healthy. Healthy is a regulatory definition that was set about 20 years ago, and it's based upon the nutrient content of foods. That science has changed. The Dietary Guidelines now really focus in on foods and food groups and dietary patterns. And so FDA has announced publicly we are updating the definition of healthy so that it will have more meaningful information for consumers to reflect current nutrition science. And at the same time, we're considering, and we've had a lot of public comment on this, an FDA-sanctioned healthy icon that could be right on the food label so that consumers can quickly identify those products that would most help them put together a healthy dietary pattern. So just to wrap up, we are working on the population prevention emphasis. I think that the statistics will bear out that much of the work that we are doing has the potential to impact the whole population and prevent tens of thousands of avoidable illnesses through our work on calories, added sugars, sodium, trans fat, and encouraging healthier foods across the board. So that's the end of my presentation. Thank you.